Good day. My name is Michelle Lavander, and I'm the founding director of the USC Center for Health Journalism. Thank you for joining us today for our Health Matters webinar, From COVID to Monkeypox, a conversation with Dr. Anthony Fauci. People are dying of COVID every day across the country, but President Biden recently declared the pandemic is over. But is it? And are we prepared as a nation to confront the next massive public health threat? Here at the USC Center for Health Journalism, we help reporters and policy thinkers investigate and respond to public health challenges across the nation. Who can better speak to the challenges ahead than Dr. Anthony Fauci, the government's leading scientific voice across 4 decades and 7 administrations? He navigated the HIV/AIDS epidemic during the 1980s and the COVID-19 pandemic and became a polarizing figure along the way. As director of the NIH's National Institute of Allergy and Infectious Diseases, Dr. Fauci now plays a key role in the government's response to monkeypox. He's announced a December retirement, and we're looking forward to hearing his vision for what lies ahead. Here to lead that conversation will be the Washington Post national health reporter, Dan Dimond. Dan is an award-winning journalist focused on accountability, federal agencies, and the coronavirus pandemic. He joined the Post in 2021 after covering the Trump administration for Politico. In 2020, he was a Center for Health Journalism National Fellow, doing groundbreaking work as part of our program on the health challenges during the pandemic of US-based Marshallese Islanders. We will be archiving this webinar later today at centerforhealthjournalism.org. A word about our format today: we'll be hearing from Dr. Fauci in conversation with Dan Dimond, and then we'll turn it over to our audience for their questions. Because we have hundreds of people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel. Now let's get underway. Dan, I'll turn it over to you.
Thank you, Michelle. It was a thrill to be a USC Annenberg Fellow a few years ago. It's nice to be back virtually. Dr. Fauci, let's get into it. On January 8th, 2020, the CDC put out an alert about a mysterious pneumonia in China. Now, 1,000 days later, COVID is still a reality. Where are we in the pandemic, and is the end truly in sight?
Well, I don't think we can say the end being no more COVID is in sight, because I think you have to think, Dan, when you're talking about a pandemic of this nature, we have had multiple waves. We've had valleys and peaks in the evolution of the outbreak as new variants came along. Right now, it's all relative. So if you look at where we are now with the number of cases, hospitalizations, and deaths compared to several months ago, when we were averaging between 800 and 900,000 cases and between 3,000 and 4,000 deaths. We're not at that point now. We're at much, much lower. But again, relatively speaking, it's less, but it is still at a level that I have been very public about saying that I'm not comfortable with, having 300 to 400 deaths per day. There's no doubt the cases, and I was on the phone with colleagues in health departments throughout the country just 2 nights ago, and everyone is having the same experience. Considerable diminution in the number of cases, number of hospitalizations and requirements for intensive care down, as well as the fact that deaths, even though they're trailing a little bit more slowly than I would like to see, they too are coming down. However, I think it would be a bit cavalier to all of a sudden say we're completely through with it, because remember, we were going in the right direction in the summer of 2021, and along came Delta. Then in the winter, November, December of 2021, along came Omicron. And since then, we've had multiple sublineages of Omicron. So let me put it this way, a little bit more long-winded than most of my answers, but it really requires that, Dan. Right now, it looks like we're going in the right direction. However, we are entering into the winter months where no matter what the respiratory disease is, there's always a risk of an uptick in respiratory diseases. Number two, even though BA.5 is still the variant that is the one that's dominant, you have the creeping up of variants that are sublineages like BA 4.6. We don't have much of BA 2.75.2 yet, but there are other countries that do have that. So although we can feel good that we're going in the right direction, we can't let our guard down. And one last point to your question, we now have available a updated vaccine that is specifically geared to the predominant circulating variant, the BA.5, which is the reason why we're encouraging people, particularly as we're now in the fall season, to get that particular updated vaccine, which fortunately for us is directed at the major circulating variant.
President Biden recently said, quote, "The pandemic is over." Given the exhortation, the encouragement to go get the booster, how does that statement, "the pandemic is over," help the federal government convince Americans who might be on the fence to take precautions?
Well, of course, Dan, it's obvious that that could be problematic because people would interpret it as it's completely over and we're done for good, which is not the case. No doubt about that. I believe what the president was referring to was that the fulminant stage that I mentioned just a moment ago, where you had 900,000 cases and 3,000 to 4,000 deaths, is now behind us. However, he did also say in the statement, however, we still have challenges ahead, and we've got to make sure we meet those challenges. Unfortunately, when it gets to the point of messaging, it's understandable how people can latch on to 3 or 4 words, and that could interfere with the incentive of getting vaccinated. And that's the reason why I myself and all of my colleagues and the president himself is out there saying, go out and get that updated shot.
Just quickly, yes or no, you talked about the circulating virus, the potential for variants that could challenge us this winter. Do you think we will be masking again at Thanksgiving, at Christmas this year?
You know, I can't give you yes or no, because when you say masking, Dan, are you talking about in a congregate indoor setting where you don't know the status of people? I believe if you get to a level of transmission in the community, that the CDC guidelines will still hold true, which means if you are in a zone of low transmissibility, masks are not recommended, but optional. Whereas if you are in a high level of transmission, I don't see any reason why you're not going to have that recommendation that they are used in an indoor congregate setting. I hope not, but that's entirely conceivable that we will see enough of an uptick that is possible, that will be required.
Are you still masking in congregate settings, Dr. Fauci? Are you eating indoors at restaurants? I'm just curious.
Well, it really depends on the situation. For example, I don't go to indoor dinners where you sit down in an indoor setting for a significant period of time. I would go to a reception, most of them outdoors, and I would not wear a mask. But if I'm in an indoor setting for a considerable period of time, I would keep a mask on. It really varies. It's not like I always wear one or I never wear one.
I see questions are coming in, which is great. We will get to those in about 20 minutes or so. Thinking about lessons learned, Dr. Fauci, the head of the CDC recently said that her agency has made mistakes throughout the pandemic. How do you think the CDC and other federal agencies have performed during COVID?
Well, I think that Dr. Walensky was quite correct and hit the nail on the head. And I commend her for the realization that there are many things that were done that really need some fundamental core rethinking about the culture there. She's very open and transparent about that. There needs to be much more of a level of transparency and much more an attention to the public health aspects of it as opposed to the academic aspects of it. So, I mean, I am perfectly in tune with her evaluation of her own agency.
This year, tens of thousands of Americans contracted infections of monkeypox, a virus that, unlike SARS-CoV-2, we've known about. We have tests, treatments, vaccines to fight it. But despite those tools, it spread. You couldn't stop it. CDC now says that it's unlikely we will eliminate monkeypox here in the States. Doctor, does the US response to monkeypox make you more or less confident about our ability to fight the next virus?
Well, I think it might be a little bit apples and oranges there, Dan. Let me explain. Interestingly, we had vaccines, we had some antivirals, and we had tests. And yet what happened with monkeypox was the evolution of an infection in an environment that really was not anticipated. Because if you go back historically, for example, at the development of the Jynneos vaccine, which is a less reactogenic, less adverse events than the typical ACAM 2000 smallpox vaccine, it was really developed almost as a backup for the smallpox vaccine were we to get a bioterror attack with smallpox. I mean, if you look historically of how all this happened, Jynneos was not developed, and that's the one that is the much more acceptable, particularly to an immune compromised group that happens to be the most vulnerable group for monkeypox. That was not anticipated. So if there was ever anything that could have been done better, would have been a more rapid deployment of these particular countermeasures.
I suppose just to follow on that, the idea that we had Jynneos vaccines either purchased and waiting to be shipped, or just the raw materials overseas and waiting on the order to turn them into vaccines, we could have moved faster on monkeypox. And doctor, I take the point, SARS-CoV-2 very different than monkeypox, apples and oranges in that sense, but the same teams, the same thinking applies when there is a public health threat. So if we're looking at the next one, do you feel more confident about our ability to fight whatever might be coming down the pike?
Well, Dan, if lessons learned are really learned, we would do better. I mean, I think if you look at the kinds of things, and I hope, and I just get back to the fact that I commend the CDC for taking a good hard look at how they've been able to respond. I hope that gets translated into a better implementation when the next threat does occur.
You and other public health experts have made hundreds, if not thousands, of recommendations, decisions over the course of the pandemic. Many were correct, some weren't. Now, doctor, I know you're a sports fan, so to use a sports metaphor, is there a realistic batting average for public health experts? If you bat 500 on your predictions, is that enough to be successful?
You know, Dan, you're right. I'm a sports fan, but 500 in baseball is unattainable, but it's not that great sometimes when you deal with the public health, because, you know, if you're out 7 out of 10 times and you're batting 300, you're a star. If you're wrong 7 out of 10 times in public health, you've done a really bad job. So we've got to be careful about the batting average analogy or metaphor. But
well, I was going to say free throw percentage, but I felt like that was too esoteric. But I'm curious, what is the right rate? Do you need to get 9 out of 10 decisions right?
You know, again, Dan, it's complicated. And I know you know that because you've been following this for a while, and you and I have had multiple discussions in the past with different diseases. When you're talking about getting it right, it really has to be put into the context of if you're dealing with an evolving situation where something from week to week or month to month evolves, you get different data, you get additional information, additional evidence, which might make you have a decision, a recommendation, or a guideline at one point in time, when a month or 2 months later, as new data comes in, it's clear that that was not the optimal choice. And if you had known then what you know now, you would have done something different. Does that count as a strikeout, or does that count as a different ball game? So I think we have to be careful about that. And I think this is particularly relevant with COVID, where in the first few months, we had an evolution of understanding that each month or week that went by, week or month, there was something different. First, well, it went from animal to human, not very good, transmitting from human to human, to, well, it is transmitted from human to human, to it's transmitted really well from human to human, to, well, my goodness, it's aerosolized too. And then finally, unlike any other respiratory disease that we've had to deal with, 50 to 60% of the transmissions were from people who were without symptoms. That was completely unprecedented. So that evolved over a period of weeks to months. So again, how do you give a batting average on that? It's very, very difficult to do, because at one point in time, you don't have the information that is really necessary to make the ultimately correct recommendation. It may have been correct at the time, but as it evolved, it turns out it wasn't correct. We've had plenty of that. Hopefully now, where we are in this outbreak, we've reached that steady state of understanding that we're not going to get, as it were, fooled. And that gets back to the question you asked, is it over? We should anticipate that we very well may get another variant that would emerge that would elude the immune response that we've gotten from infection and or from vaccination. I hope we don't get that, Dan, but we should not be surprised if we do.
Just getting back to lessons learned, Doctor, and I'll ask the question a slightly different way. Earlier in the pandemic, you and other experts had recommended that average Americans didn't need to wear masks. Now that changed. I take the point that things evolve as we learn more. Later, you told the New York Times that the target percentage, how many Americans needed to be vaccinated for herd immunity, that you'd been steadily raising that from as low as 60% to over 80%. More recently, we just spoke about monkeypox. There are many public health experts who did not lean into warnings that gay men were contracting monkeypox through anonymous sex. They were nervous about stigma. Do you think public health experts have challenges delivering hard truths to the American people?
Yeah, I mean, yes, I have tried always to give the hard truth, but very often the hard truth is not heard under the circumstance in which it's given. But I mean, one of the things that we was hopefully continue to try to do is to give the hard truth. One of the problems, Dan, and you know this, is that when you talk about the hard truth and say it in a sentence, given social media and how things are misinformation and disinformation, a lot of times there's a lot of misrepresentation of what a message is. If we had true honesty, true transparency, not things get entangled with social media, it would be much easier to get a coherent message that people would understand with a realistic understanding of what risks are. But that gets all gobbled when social media comes in with disinformation and misinformation.
Well, that makes me wonder, Doctor, you're venerated by some Americans, you're hated by others. Of course, that's a familiar dynamic for the journalists watching this interview. Having lived through more than 2 years of intense scrutiny, is there anything you wish you had done or said differently, particularly given the climate that you just mentioned with social media?
You know, the answer is yes, Dan. I mean, my goodness, no one's perfect. Certainly I am not. When I go back in the early months, I probably should have tried to be much, much more careful in getting the message to repeat the uncertainty of what we're going through. I tried that. I mean, you remember some of the famous quotes that get thrown back at me when I said, at this particular time, we should not necessarily do anything different. That's when there was like 5 cases in the country. But then I said, I kid around about it, it was semicolon, however, comma, this could change rapidly and we need to be prepared. When the only thing that gets thrown back at you is, oh, well, you said back then we didn't really need to change anything that we were doing. Well, as a matter of fact, that was true. But if you wanted to say, if we knew then that this virus under the radar screen was transmitting in a way that was not fully appreciated. And any of us would have said, hey, you know, we've had 5 cases in the country. We need to shut down. People would have looked at us like we were crazy. But yet again, maybe that was the right message back then. Maybe, I don't know.
Well, in a world where people don't hear what's after the semicolon, they don't hear the second sentence after President Biden says the pandemic is over, does that change the kind of message that needs to be delivered? If you're only going to get 7 seconds, 1 sentence that might stick with people?
Yeah, the answer is you have to be very careful and think about what your words are for the very same reason that you just mentioned, Dan. It is really unfortunate that that's the world in which we live, in that it's a bunch of sound bites that sometimes get cut in half and get misinterpreted. It isn't always that we get the opportunity of the audience that's listening now that listens to all of the nuances that we're talking about. But what almost certainly will happen is that someone will take a clip of our conversation now and distort it. Whereas the people who are looking at all of the conversation, all of the nuances that are going back and forth between you and I, that would be the honest approach to it. But someone can always make mischief by clipping out a few words.
Well, let's hope that everyone is watching all 45 minutes of the USC Annenberg seminar, which is my endorsement. But doctor, as we think about early decisions in the pandemic or how things are covered, I have wanted to ask you this. You've become a major target of scrutiny for congressional Republicans. They've released some of your emails as part of an investigation into the origins of the pandemic. And in April 2020, you reportedly wrote an email to Francis Collins, the director of the NIH at the time, where you predicted that attention on the lab leak theory was a fad. Quote, it is a shiny object that will go away in times, end quote. Of course, it hasn't gone away. According to some polls, most Americans now believe that a lab leak is the likely cause of the pandemic. Why do you think, doctor, you misjudged the interest in the lab leak theory?
Well, I don't think I misjudged the interest. There's always the concern, and I have kept a completely open mind about the possibility that there may have been a lab leak. But one thing you cannot walk away from, Dan, is that lab leak is a theory with no evidence whatsoever. Do we keep an open mind? Absolutely. In fact, early on, when there was the suspicion about it, I was part of the group that called together a bunch of experienced evolutionary virologists to seriously look at that. And they did, Dan, and they looked at it carefully. They went over the epidemiological, the virological data, and they published in the peer-review, high-ranked journals their conclusion that it is most likely a natural occurrence. At the same time that they say we all must keep an open mind that it was a lab leak. But there's evidence to strongly indicate that it is a natural occurrence and zero evidence to indicate that it's a lab leak. Does that mean it didn't occur or couldn't occur? No. And that's the reason why I continue to emphasize that we all should keep an open mind, even though the evidence from a diverse array of international evolutionary virologists feel rather confident that it was a natural occurrence.
As part of the probes into the lab leak, EcoHealth Alliance, which conducted so-called gain of function research on coronaviruses in China, there are reports that it is again being funded by your agency. Now, politicians and some watchdogs have said EcoHealth and your agency haven't been fully transparent about the research into dangerous pathogens. Why are you confident, doctor, that EcoHealth is a good funding partner for your agency here? If we're keeping an open mind, is it too early to go back to funding EcoHealth?
Well, EcoHealth has grants that have nothing to do with what we're talking about, that are looking at surveillance in different countries. And when they put a grant in, and there are administrative issues related to another grant, not the grants that are getting ready to be funded. And the administrative structure of the NIH, which is fundamentally an NIH central, gives a list of administrative things they need to address, and they adequately address it. There is really no mechanism to say arbitrarily, we can't fund you, even though you've been peer reviewed and highly recommended for funding, because someone doesn't like you. I mean, if they ever brought that in court, they could sue us and win that in a microsecond. So you've got to be careful. It's kind of like saying that there is a grant from an institution in the United States that's something really bad about that grant, and therefore you shouldn't give any funding to any other element of that institution. You've got to be fair, and you've got to go by process, not arbitrary deciding whether you want to fund something or not. You go by as an established NIH process. If something is peer reviewed, gets a high recommendation for funding, you can't arbitrarily decide, I just don't want to fund it because people don't like them.
One more question on the Republican probes. They have said, lawmakers that might be in charge of the House or the Senate next year, that they will call you back for investigations next year if they retake the majority. Are you going to sit for interviews with Republicans next year on the coronavirus?
If they call me, of course. I have no problem. I am a big believer in oversight, and I have testified before Congress literally hundreds of times. I have no problem testifying before Congress.
I have one more question, and then we'll start taking questions from the crowd. And that's about your path. You have been in service, as Michelle said in the beginning, for over 50 years. You've led your agency for decades. Do we need another Dr. Fauci, someone who can be a public spokesperson, who can advise presidents? Or is your experience of being scrutinized, attacked, an illustration that this model of a singular public health figure doesn't really work anymore?
Well, it depends on the environment in which you're in. It's no secret that we are living through one of the most divisive eras, really, in the history of the country. There have been several in the past, and they've all been really quite serious. Under normal circumstances, I think to have a public health figure who's a scientist who can advise on certain elements of public health is important. And there will be another Fauci, not exactly like me, just like I'm not exactly like anybody else. But I think you have to take into account the difficulty we're in now when we have such a degree of divisiveness. And if ever there was a time in history in which there should not be the kind of divisiveness that we have, is that when the country is facing a pandemic, the likes of which we haven't seen in over 100 years. That's the worst possible combination.
Do you have anyone in mind who will take over for you at your agency?
No, but I'm sure they will find someone, Dan. They'll do a national search and they'll find someone.
Well, maybe the next Dr. Fauci is watching us now. Let's turn to the questions that have come in. There are quite a few, and I'll start with this question from Margaret Tate. Doctor, do you have ideas of how best to highlight, quote, public health wins, such as the narrowing gap in deaths and infections by race and ethnicity? I assume that's about COVID, and to motivate a culture of complacence that enough has been done. So how to highlight public health wins?
Well, yeah, I mean, one of the things that we've learned through this is that a public health win, the biggest win, had to do with the science that is part of the comprehensive approach to a public health challenge. And I bring that up quite often. It relates a lot to the institute that I direct, that the investments in basic and clinical research over the 15 or more years that antedated COVID-19 led to the unprecedented accomplishment of developing, testing, and having ready to go into the arms of individuals a safe and effective vaccine, literally within less than 1 year from the time the virus was identified. That's a big win. And the lesson for that is always continue to have a robust support for fundamental, basic clinical and applied science, because if we didn't have that, we likely would not have the vaccines that we have right now. Now, with that are a lot of challenges, and you just mentioned one of them. The thing that's been very painful to observe on my part and the part of my public health colleagues is the disparities in health in our nation. We saw that brought out with HIV, where you have 13% of the population is African American and 44% of the new cases of HIV are among African Americans. We saw it with COVID, when the level of severity of disease and death and hospitalization among brown and Black people is substantially greater than the general population because of the social determinants of health, which put brown and Black people in a situation where they have a much higher incidence and prevalence of those underlying conditions, which make it much more likely that they will have a severe outcome. So there are wins and successes, but there are cold and very difficult lessons that we need to learn. And one of them I mentioned is the health disparity.
We have several dozen questions, so I'll do my best to get in as many as we can. This is from Susan Bliss. Dr. Fauci, does CDC and FDA and other agencies need to create a rapid response team to respond to sudden changes needs and outbreaks?
Well, the answer is yes, but they do have a rapid response team, and that is the group that are the Epidemiologic Intelligence Service. The problem is that that was not fitted for a global pandemic, the size and magnitude of which we're facing. So right now, they are putting together a team that could address the situation we were faced that they likely were not as well prepared for. So hopefully the relooking, the internal self-examination that the CDC is doing will greatly improve their ability to respond to future challenges.
There are several questions that get to this issue of HIV, AIDS, and lessons learned or not learned. This is from a person, forgive me if I'm mispronouncing, Smitha Khurana, who says, with all due respect, doctor, the same mistake was made with HIV, AIDS in the 80s and 90s, and then goes on to say that folks were reporting long COVID and debilitating symptoms early in the pandemic that were ignored, much like how early HIV, AIDS cases were also ignored. Doctor, what does that say to you about what we have learned or really haven't learned in the past decades?
Well, I'm not so sure what they were talking about ignoring things with HIV. When before we had a diagnostic test, we didn't know the scope of HIV. I was taking care of patients with AIDS who were desperately ill, and they were the tip of the iceberg before we had a test to show many people were positive and had not yet gotten ill. So I'm not sure what really the basis of that question is. With regard to long COVID, it's a real phenomenon, and we really have to deal with it. And we recognize that very early on. I mean, it's a very, very interesting situation now that anywhere from 5 to 20% of people, even those who don't have very severe COVID, can have persistence of a strange array, strange in the sense of not totally explainable by an identifiable pathogenic process. And that's something we absolutely have to get our arms around, find out what the pathogenic mechanism of it is, and then hopefully do something about it. It's a very serious problem. We did recognize that early on.
This webinar is being hosted by a journalism program. There are some journalism questions, including from the Center for Health Journalism, our host. What stories do you feel that journalists have missed that you would encourage us to pay attention to in the coming months, the center asks?
You know, I would pay attention to the lack of, and this has to do a bit, Dan, I think, with messaging, but the lack of acceptance of the need for individuals to get vaccinated and ultimately keep updated on your vaccines. It seems so extraordinary that when you look at the data of the deaths and severe disease among unvaccinated versus vaccinated and boosted versus vaccinated and doubly boosted, the data are crystal clear of the difference in severity and death among people who are not vaccinated. And yet in this rich country of ours, we have 68% of the population is vaccinated, and only 1/2 of those have received one booster. So when you rank us with the rest of the world, both the developed world and even several low and middle income countries, we rank very poorly in our acceptance of vaccines. Somehow we've got to get down to the root cause of that. And I know it's going to be very complicated because a lot of it is because of political divisiveness. I mean, there's no secret that red states are under-vaccinated and blue states have a high level of vaccination. That should never be that a public health determination is made and influenced by what your political ideology is.
We have a question from Carmina de Santiago, which I've had too. Many public health professionals aren't political figures, but are finding themselves in battles with political figures. Do you have advice, Carmina asks, for those who are in public health roles in local governments? I suppose that would also hold true for journalists who find themselves scrutinized as you have.
Well, I think the important issue, what I've tried to do, is to just stay out of the politics and just stick with the science and the data. Now, when you have,
but doctor, that hasn't really worked for you.
well, I still stick with the science and the data. You hear them, people say polarizing figure. Well, when I say we should get vaccinated because it saves lives, and someone says no, am I the polarizing figure? Or is the person who's saying something that's completely untrue creating the polarization? Some people say hydroxychloroquine works. It's the end all. I say there's no data that show that it works. Am I being politicized? Am I polarizing? I don't think so. I'm just sticking with the data.
There's a question from Rena Betancourt, forgive me if I'm mispronouncing her name. What advice would you give for newer public health employees coming into the field within the last few years?
Again, I think it's very much similar to the answer to a question I just gave, Dan, is that stay out of the political issues and focus purely on evidence, science, and data. That's the thing that you've got to focus like a laser beam on, which is what I've tried to do. And I think successfully. People have distorted things, but I have focused as best as I possibly could on the science and the data. That has put me in conflict with people who would, as a result of that, attack. There's not much I can do about, but continue to focus on the science.
We're getting many questions about the politics in public health right now. I suppose Dana McMurtry asks, can we educate the public about the inexactitude of science and the need to change our understanding as science evolves, or is science just too politicized now?
No, I don't think it is too politicized. I think that we can and should continue to try and get the public to realize, I mean, less the inexactitude of science, but that science gets data and evidence evolves and changes. And I think that's one of the things it would be wonderful if we could get a better understanding on the part of the public, that as you are in an evolving situation, the information that you get will evolve and you need to change. That's the nature of science. You've often heard that science is self-correcting, which means if you continue to adequately collect information and data, as that information and data change, then your recommendation, your stance, your guideline, or whatever should change. Some people say that's flip-flopping. It's not flip-flopping. It's the opposite of that, because if you want to really be true to the science, you will evolve your thinking as the data changes and evolves.
What's one thing you would fix in healthcare delivery? So going beyond federal recommendations, beyond the politics, just thinking about care at the bedside that would have the biggest impact on public health.
Well, I think it would be the uniformity of the health system, of uniform access to and records that are interchangeable. I mean, it was very interesting, Dan. It hits on a real sore note among us, is that we have such a fragmented healthcare system in this country that if you wanted to get real-time, real-world data, particularly in the context of an outbreak as it's evolving, some of our data takes months for us to really get it. Whereas we had to turn to our colleagues in the UK and in Israel that had a healthcare system that could give you essentially in real time the data of what was going on in the country. That's one thing that really needs to be fixed, to modernize our ability to get real time data, not data that's 2 and 3 months old.
You're the president's chief medical advisor. You've advised multiple presidents. You're also roughly the same age as President Joe Biden. His age has come under some scrutiny. Do you think we need to take age into account when thinking about fitness to serve as president?
Well, I would say no, and let me explain to you why. It depends. I mean, if someone's 104 years old, yes. But when you're talking about someone who's elderly, it really is how fit that person is. You know, we have 55, 60-year-old people who appear to be worn out. You wouldn't want them to take the job of leading a country. And there are others who are in their 70s and maybe even 80s. I mean, I'm 81. I'm going to be 82 in a couple of months. I haven't missed a step in my job that I've been at for 38 years. It really depends on the individual. I don't think you can arbitrarily say, if this person is at this age, therefore you're going to put them in a certain category. It all depends on the mental and physical fitness of the person.
What's the secret to getting things done in the federal government?
Persistence. You really
Anything more than that?
Yeah. Well, no, Dan, you very often get what you need to get done on the first shot. You've got to be able to have the persistence and the energy and the resilience to accept disappointment, but keep your eye on the ball of what you need to get done.
I think we have time for just a few more questions. So Kayla Petaprin asks, I'm wondering, doctor, if you think we'll ever know the true origins of SARS-CoV-2.
Well, I hope so. And I think, you know, we found out pretty conclusively what the true origin of SARS-CoV-1 was when it was a bat to an intermediate host, an animal, which then jumped species into a human. I would hope that we would get greater cooperation from the Chinese to be able to do surveillance studies in China with their cooperation. That would, I think, go a long way to definitively showing what looks like the most likely explanation is a natural occurrence, as I mentioned, as that international group of evolutionary virologists have written in a peer-reviewed journal, Science, a couple of really good papers. But to nail it down, we'd need more cooperation.
China remains committed to a zero COVID strategy, even as we and other countries have opened up. Do the Chinese know something that we don't, doctor, about this virus and its long-term effects?
No, I don't think so at all. I think that when you have a shutdown, a strict shutdown policy, it should only be done if, for example, your hospital system is being overwhelmed, which was the reason that triggered the partial shutdown that we had in the beginning, because you might remember New York, the hospitals were on the brink of being overrun. But when you do that, you should do it to allow you to do something that would permit you to safely reopen, which means the Chinese should be vaccinating everybody in their population. And I'm not sure they're doing that. I would hope they are, because that's the solution and the counterpoint to a no COVID policy. Get your population vaccinated.
I think this is going to be the last question, Doctor. As you look ahead, how can the US focus on health equity and vulnerable populations in its future response to mass public health emergencies like COVID?
Well, as I mentioned in answer to a prior question, it is a big problem of the health inequities and the disparities that comes out every time there's a health process. That requires, Dan, a decades-long commitment in neutralizing those health disparities, which are a result of social determinants of health that is, I believe, deeply rooted in the original sin of racism. We've got to get over that and make sure that there is equity in our ability to get care to people, as well as the very subtle social determinants of health that lead to an increased incidence and prevalence of things like diabetes, hypertension, obesity, chronic liver disease, chronic kidney disease. Those are not racially determined. Those are due to social determinants of health. We need a decades-long commitment to overcome that.
Well, Doctor, thanks so much for joining for this conversation. On behalf of USC Center for Health Journalism, I know there were many people with questions for you. Thanks for getting to as many as you could.
My pleasure. Good to be with you, Dan.
Thank you so much for joining us today. I'm having a little problem with my self reappearing, but this is Michelle Levander. I want to thank you, Dr. Fauci and Dan Dimond. We're so pleased to have you with us. In case you're one of the hundreds of journalists participating in this webinar today, we would like to share in the chat word of some of our upcoming journalism programs and grant opportunities. Next up are 2 programs for California-based reporters. I wanted to thank and acknowledge the generous support of the National Institute for Healthcare Management Foundation, the Commonwealth Fund, and the California Endowment in supporting our webinar series, as well as individual supporters like you. I want to thank our team here at the Center for Health Journalism, including Ryan White, our content editor and webinar lead, and Harold Pierce, who heads up our outreach effort. And we would also like to thank our audience and invite you to support our continuing series. It's through the support of individuals like you that we were able to host these webinars. Please also take a moment to fill out our survey after this webinar and let us know what topics would be of greatest interest to you for the next one. I'm Michelle Levander. Thank you for joining us and have a wonderful day.